Good afternoon and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with commercial interests. If you have a question for our presenter today, please hold until the Q&A segment at the end of the talk. If you're attending virtually and have a question, please enter it into the Q&A section and we'll be sure to ask that for you. Also, a link to the event survey will be shared at the end of the program. It is my pleasure to introduce our guest speaker today, Dr. Nivedha Balaji. Dr. Balaji is a third-year internal medicine resident at Northeast Georgia Medical Center. She earned her Doctor of Osteopathic Medicine degree from the Philadelphia College of Osteopathic Medicine on the Georgia campus as a proud member of the class of 2022. She will soon be continuing her training in nephrology at the University of Massachusetts Chan Medical School. Dr. Balaji's clinical interests focus on diabetic neuropathy and hypertensive kidney disease, areas in which she has demonstrated both passion and expertise. Join me in welcoming our guest speaker.
So my name is Nivedha Balaji. My interests are diabetic nephropathy, not neuropathy, but close enough. So I'll be presenting on metabolic syndrome and its effects on the Reno-vascular system. Like Jennifer said earlier, no financial disclosures. So our objectives for today include, so we want to study the global implications of metabolic syndrome and understand the signs and symptoms suggestive of it, understand the mechanisms involved in Reno-vascular injury, apply the updated guidelines and emerging research findings towards the management of metabolic syndrome, implement evidence-based management so we can prevent and treat the condition. So what is metabolic syndrome? It's a constellation of metabolic derangements composed of visceral adiposity or central obesity, insulin resistance, hyperglycemia, hyperlipidemia, or dyslipidemia with hypertension. Why is it important? Well, it increases your risk for atherosclerotic cardiovascular disease, type 2 diabetes, non-alcoholic fatty liver disease, myocardial infarction, stroke, and chronic kidney disease. So the definition of metabolic syndrome includes, or diagnostic criteria is when you have 3 or more of the following characteristics. When you have elevated waist circumference, and this is population specific. In the European continent, a waist circumference greater than or equal to 94 centimeters in males or 80 centimeters in women is considered an abnormal elevation, whereas in America, we use 40 inches, which is approximately 101 centimeters, or 35 inches for women, which is approximately 89 centimeters. You can have elevated triglycerides greater than 150 milligrams per deciliter, or reduced high-density lipoproteins less than 40 in males and less than 50 in females. An elevation of systolic blood pressure greater than 130, or elevation in diastolic greater than 85, along with an elevation in glucose greater than or equal to 100 milligrams per deciliter. So having at least 3 of these above mentioned findings qualifies you for metabolic syndrome. So why is it important? Well, it affects about up to 39% of the worldwide population, about 1/4 of the Latin American population, and 1/5 of the American and European population. It's prevalent in women and men, affecting about 22% in women and 24% in men. It's prevalent in both rural and urban populations, 12% in rural populations, and a little bit more, 22.5% in urban populations. Unfortunately, this is a disease that's spread across ages. It's present in children. The incidence rate is about 3% and about 20% in adolescents. So let's talk about metabolic syndrome and chronic kidney disease, the interplay. Right now, we know that about more than $500 billion is spent annually in the United States for healthcare expenditure. And there's also an indirect cost related to economic loss driven by reduced productivity. We know metabolic syndrome increases morbidity and excess premature mortality. There is an association with an increase in development of chronic kidney disease, and it's up to 4.4-fold. With rising incidence of metabolic syndrome, there is a rise in metabolic syndrome-associated complications like chronic kidney disease, cardiovascular disease, stroke, etc., resulting in a rise in healthcare costs. So it's important for us to understand the pathogenesis of metabolic syndrome, elucidate how to prevent or delay progression of these complications. So metabolic syndrome-related Reno-vascular disease. Before we go into the pathomechanisms of that specifically, let's define chronic kidney disease. So when you have one of the following symptoms for at least 3 months or more, then you're said to have chronic kidney disease. An estimated glomerular filtration rate less than 60, or urinary albumin to creatinine ratio greater than 30 milligrams per gram, or urinary albumin excretion rate greater than or equal to 30 milligrams per day. Chronic kidney disease is a global epidemic present in up to 14% of the worldwide population. In 2016, there was an estimated 26 million individuals in the United States living with chronic kidney disease. Now, this could be stage 1 through 5, which is ESRD. The pathomechanisms related to metabolic syndrome-related CKD involves insulin resistance, central adiposity or obesity, hypertension, inflammation, oxidative stress, and hyperuricemia. So the next few slides are heavy in details, but let me kind of summarize everything so it makes sense. Insulin resistance and hyperglycemia is associated with the complications of metabolic syndrome. You have insulin-like growth factor, which releases prostaglandins, or along with prostaglandins, bradykinin, nitric oxide, atrial natriuretic peptide, thromboxane E2, causes the afferent arteriole to dilate and the efferent arteriole to constrict, thereby resulting in glomerular hyperfiltration. Hyperinsulinemia also regulates endothelial nitric oxide synthase in the vascular and renal tissue. This results in further hyperfiltration of the glomerulus. With excess nitric oxide, you also have vasorelaxation, leukocyte-monocyte adhesion to the renal vasculature. There's platelet aggregation and promotion or induction of further pro-inflammatory pathways. Hyperinsulinemia also increases endothelin-1, which is a potent vasoconstrictor. Now you have vasodilators, you have vasoconstrictors. All this input causes microvascular endothelial dysfunction. You have capillaries that become quite permeable, resulting in macromolecular leakage and proteinuria or albuminuria. Insulin resistance also causes podocyte loss that promotes shedding of the glomerular basement membrane. You have, again, further leakage of macromolecules and proteinuria. Hyperglycemia also releases chemokines like ornithine decarboxylase, which causes increased filtration and renal hypertrophy. Now, SGLT2s are involved in the hyperglycemia pathway, where you upregulate SGLT2 transporters to allow for maximal reabsorption. Let me go back. So hyperglycemia also results in SGLT2 upregulation in the proximal convoluted tubules. This allows for the individual to urinate the excess glucose. But because of this, you have maximal reabsorption within the proximal tubules, resulting in increased glomerular filtration, triggering the RAS system, causing elevation in blood pressure. Now, we also have further inflammation. Now, I've talked about insulin and hyperglycemia-induced inflammatory pathways, but central adiposity also results in increased inflammation. Now, there's a term that can be coined here, metabolic syndrome-induced inflammation can be called meta-inflammation. Insulin resistance leads to production of these molecules called advanced glycation end products, which are called AGEs. And these synthesize nuclear factor kappa B, reactive oxygen species, which cause cellular growth, hypertrophy, inflammation, angiogenesis, endovascular dysfunction, and extracellular matrix deposition. When you have hyperglycemia, you activate a molecule called protein kinase C, which increases endothelial permeability and synthesizes extracellular matrix proteins that propagate vascular dysfunction, stimulates nuclear factor kappa B, releases interleukin-6, tumor necrosis factor within the endothelial and mesangial cells. So when you have these molecules of advanced glycation end products and protein kinase C, you turn away from the glycolytic pathway to a more inflammatory pathway like the polyol and hexosamine pathways, which induce more oxidative stress via nuclear factor kappa B and TGF-beta 1. You also have adipocytokines, which recruit pro-inflammatory macrophages that cause glomerulosclerosis and widespread fibrosis, again resulting in proteinuria and renal dysfunction. Reactive oxygen species in the kidneys alter the renal tubular transportation. They induce TGF-beta 1, trigger nuclear factor kappa. They cause fibrinolysis. They increase the NADPH pathways within the B cells. You have overexpression of certain molecules like zymogen activator inhibitor 1, which causes further fibrosis of renal tissue. Leptin is released when you have increased adiposity, and that causes increase in angiotensin 2, aldosterone, plasminogen activator inhibitor 1, TGF-beta 1, again activating the pro-inflammatory pathways and increasing the activation of the RAS system, which causes an elevation in blood pressure. So furthermore, we have insulinemia that propagates lipid accumulation in the tubular cells, which causes or leads to tubular atrophy and interstitial fibrosis. Hyperinsulinemia causes a production of insulin-like growth factor, which stimulates connective tissue growth factor, and that has pro-fibrinogenic effects. That causes tubular fibrosis and interstitial fibrosis. Insulin-like growth factor also is involved in decreasing matrix metalloproteinase 2 activity, which is normally involved in breaking down the extracellular matrix. But with a decrease in that protein, now you have excess deposition of ECM, but you don't have degradation of it. So you have renal hypertrophy and dysfunction and fibrosis. Hyperinsulinemia and dyslipidemia via cytokines like TNF-alpha, interleukin-6, induce neovascularization. So you have overexpression of VEGF that causes all these new microvessels to form, which is great, right? It increases blood flow to the kidneys, increases GFR, so kidneys should be happy. But because of that increased hyperfiltration and more blood flow to these naive new vessels, you have vessels that become more tortuous and unstable, resulting in macromolecular leakage, causing proteinuria. So let's talk about how hypertension is involved and how the renin-angiotensin-aldosterone system is involved in metabolic syndrome. So when you have increased adiposity or visceral adipocytes, you have an increase in angiotensin 2, angiotensinogen precursors, aldosterone. All that causes fibrotic activity in the Reno-vascular system. You have increased activation of the RAS. You have higher volume burden, hyperfiltration, damaging the glomerular filtration barrier. Increase in adipocytes and obesity also causes an activation of the central pro-opiomelanocortin pathway. This results in elevated blood pressures. You have activation or dysregulation, really, of the cardiac and renal baroreceptors. So you have overactivation of the sympathetic nervous system, again, further causing elevation in blood pressure. Adipocytes also release leptin, and it reduces the production of adiponectin. This causes an increase in aldosterone, which causes an increase in blood pressure, and it also releases alpha melanocyte-stimulating hormones. That causes a stimulation of the central sympathetic nervous system. Now, another thing that is also involved is just with central adiposity, you have an increase in intra-abdominal pressure. Then that translocates. You have compression of the thin loop of Henle and the vasa recta in the renal medulla. You have decrease in the tubular flow rate and sodium excretion rate. So now the renin stimulates the macula densa to hopefully increase blood flow so you can increase sodium excretion and increase that tubular flow rate. Obesity-related glomerulopathy. So with increased adiposity, you have mechanical stretching of the podocytes, which are the FIT processes. They become less dense, but they increase in width. This results in podocytes to detach from the glomerular basement membrane and causes segmental sclerosis, again, resulting in macromolecular leakage and proteinuria. About 12% of individuals progress from this segmental sclerosis to a disease called focal segmental glomerulosclerosis. Now, with obesity, you also have excess adiposity. You also have excess fats around the kidney tissue. So excess perirenal lipids results in promoting an oxidative environment, triggering the inflammatory and oxidative paths. It also triggers the cytokines and cytotoxic effects via triglycerides. So you have toxic accumulation of metabolites like ceramide, which promotes intrinsic renal cell apoptosis. Extrarenal or excess perirenal lipids also causes endoplasmic reticular stress, resulting in mitochondrial dysfunction and cellular apoptosis. The incidence of obesity-related glomerulopathy has increased tenfold in the last 15 years. So there's multiple factors that are impacting chronic kidney disease and metabolic syndrome, so it's important to understand all these pathways, but also recognize that everything kind of is interconnected. Oxidative stress. We've talked about some of the pathways, how increased adiposity causes an increase in reactive oxygen species and hyperglycemia, hyperinsulinemia being involved in this process. Let's dive a little deeper. So when you have lipid peroxidation, which is breakdown of the fatty acids, you generate low-density lipoproteins, and they tend to accumulate in the renal mesangial cells. They generate foam cells. You have activated macrophages that impairs vasodilatory action, damages the endothelium. Lipid peroxidation also generates further activation of reactive oxygen species and free radicals that augment kidney damage. You have upregulation of NOx enzymes or nicotinamide adenine dinucleotide phosphate oxidases, which are involved in stimulating reactive oxygen species in the kidneys, leading to damage to the podocytes, the mesangium, the endothelial cells, etc. When you have inappropriate activation of these NOx enzymes in the pancreatic beta cells or the liver tissue, it results in glucolipotoxicity. Again, promoting progression of metabolic syndrome and progressing that to diabetes. Mitochondrial dysfunction. So oxidative stress results in an overproduction of prostaglandin E2 and overactivation of COX-2 gene transcription. This activates downstream the nuclear factor kappa B. It results in increase in angiotensin II, then propagates this vicious cycle that causes mitochondrial ROS production. In metabolic syndrome, you have a surplus of nutrients. People are obese, they have a lot of intake. This can augment the electron supply chain to the respiratory chain, resulting in, but due to the low demand for ATP, now you're getting a lot of nutrients, but you don't have a need to use them because you're immobile or lack of physical activity. So this generates a disproportionate number of superoxides, again, further damaging the mitochondria, resulting in its dysfunction. Reactive oxygen species also disrupt the electron transport chain. It impairs mitochondrial function and deposits further extracellular matrix proteins. This expansion within the kidneys of the mesangium and accumulation of the cellular debris is what we call Kimmelstein-Wilson nodules. There's another pathway that's also involved in mitochondrial dysfunction. So when you have generation of mitochondrial reactive oxygen species, you inactivate the AMPK pathway. Now, normally that's involved in inhibiting mammalian target of rapamycin, which inhibits NOx-induced podocyte dysfunction. Mitochondrial malfunction has been associated with the development of type 2 diabetes, and studies have shown that in peripheral blood cell preceding the diagnosis of type 2 diabetes. When you test them, there is a 35% reduction of mitochondrial DNA. So hyperuricemia. Now, hyperuricemia is defined as elevated uric acid greater than 7 in males or 6 in females. Classically, this has been linked to gout, but there is more thought that this can be associated with cardiovascular disease and metabolic syndrome. The prevalence of metabolic syndrome in patients with uric acid levels less than 6 is about 5.9%, but that number goes up to 59% if you look at people with uric acid greater than or equal to 10. So this makes us consider maybe or wonder whether this is an early marker or a pathogenic factor involved in metabolic syndrome. Maybe it impairs insulin signaling. Maybe it promotes oxidative stress and endothelial dysfunction. We do know that there is an elevation of fructose in patients with metabolic syndrome, and we know that fructose intake increases uric acid synthesis. With uric acid, you stimulate hepatic fat deposition that impairs nitric oxide bioavailability, causes insulin resistance and hypertension. So with uric acid that inhibits nitric oxide production, you also impair vasodilation. You have an increase in glomerular capillary wall vulnerability and permeability, again, just resulting in macromolecular leakage and micromolecular leakage with albuminuria. So we have metabolic dysfunction-associated fatty liver disease, which is increased fat deposition in the liver in the absence of alcohol intake or other secondary causes like Wilson's disease, but in the presence of metabolic risk factors like obesity, hypertension, insulin resistance, and dyslipidemia. Patients with metabolic syndrome have a 3.7-fold increase or higher incidence of having MAFLD. So there is this bidirectional relationship between insulin resistance and dyslipidemia seen in metabolic syndrome and metabolic dysfunction-associated fatty liver disease. When you have insulin resistance, it propagates lipotoxicity, causing lipid accumulation in the hepatic tissue, causing downstream inflammation, both within the liver, but also extrahepatically. This inflammatory process stimulates cytokines downstream, causing a metabolic imbalance and further propagating metabolic syndrome. So it's essential to understand the disease and the pathways and recognize that there are hyperinsulinemia or hyperglycemia, insulin resistance, and increased adiposity, hyperuricemia. All these pathways are probably involved in creating a pro-inflammatory state and oxidative pathway activation. But recognizing this earlier helps us prevent and manage patients. Sometimes you can delay complications from metabolic syndrome for years, and that's definitely a positive both for the patient, but also the healthcare system in general. We know that uncontrolled metabolic syndrome puts you at a higher risk for developing rapidly declining kidney disease. The risk is 3.28 times greater if you have uncontrolled metabolic syndrome when compared to controlled. So early recognition and treatment is important in preventing and delaying progression of renovascular disease. So let's talk about some of the therapeutic options available. So lifestyle modifications is one. First thing we always tell our patients when they walk into our clinics in internal medicine is lifestyle modification, regardless of the condition that it is. Our goal is to promote an environment or promote a dietary habit where you have a lot of fruits, vegetables, whole grains, legumes, nuts, not a lot of processed foods or refined carbohydrates, avoiding saturated fats and increased sodium. You also want to promote a lifestyle with more physical activity. Avoid tobacco products, have a good sleep hygiene, reduce alcohol intake, reduce caffeine intake. So you want to promote that balance between caloric deficit and also increase physical activity. So our goal is to reduce your body weight by 10% over 12 months, or target for a BMI less than 25 kilograms per meter squared. So we also have recommendations by the American Heart Association and American College of Cardiology, which states that On a weekly basis, you want to have at least 150 minutes of moderate intensity activity or 70 minutes of high intensity activity. Of course, if patients are willing to do more and that helps them, then we definitely recommend that. But when lifestyle modifications are not enough, then we need to consider pharmacologic agents or surgical agents. So for weight loss, we know that weight loss improves both inflammatory and anti-inflammatory markers, like tumor necrosis factor, interleukin-6, leptins, but also adiponectin. Previous studies have shown that even a 5% reduction in weight in obese women has shown a reduction in the activation of the RAS system. We have sympathomimetics like phentermine, diethylpropion, which suppress appetite. Now, of course, these medications have other side effects, especially if you have uncontrolled hypertension. You would want to avoid this medicine. You have orlistat, which is an intestinal lipase inhibitor that reduces lipid absorption by up to 30%. Topiramate, a carbonic anhydrase inhibitor that promotes taste aversion and reduces caloric intake, usually given with phentermine. You have bupropion, naltrexone, which is a combination of a dopamine and norepinephrine reuptake inhibitor with a mu-opioid receptor antagonist, decreases your cravings and appetite, but it is associated with nausea, vomiting, constipation, dry mouth, and more. Now, we have glucagon-like peptide 1, which has become the newer thing. Semaglutide decreases appetite and increases satiety. These medications, like semaglutide, liraglutide, are contraindicated if you have a personal or family history of medullary thyroid cancer. We have tirzepatide, which is a dual glucagon-like peptide 1 and glucose-dependent insulinotropic peptide receptor agonist. It reduces caloric intake, increases insulin sensitivity, and increases glucose and triglyceride uptake in adipose tissue. Multiple trials have been done for this medicine. The SURMOUNT trials, which is a series of 5 trials, noted that tirzepatide was associated with significant weight loss. It improved glycemic control and improved cardiometabolic risk factors. The Synergy NASH, which is a phase 2 study, noted a greater proportion of individuals achieved resolution of metabolic-associated steatohepatitis without liver cirrhosis when taking tirzepatide compared to a placebo when checked 52 weeks after treatment. We also have setmelanotide, which is a melanocortin-4 receptor agonist that decreases appetite. Now, it is given to patients when they have a monogenic obesity secondary to pro-opiomelanocortin, proprotein convertase, or leptin receptor deficiency. This is commonly associated with hyperpigmentation because it goes through the POMC pathway. There's also Gelesis 100, which is a hydrogel matrix composed of cellulose structures cross-linked with citric acid. It increases water absorption, thereby reducing your hunger and improving satiety. This is associated with bloating, infrequent bowel movements, dyspepsia. This is not used as often because of the side effects. There are other medications out there that are given for another purpose, but have been associated with some weight loss. Bupropion is one of them. It's a norepinephrine dopamine reuptake inhibitor. Most of the antidepressants are associated with weight gain, whereas this one has shown a small benefit in weight loss. Metformin suppresses gluconeogenesis, increases peripheral insulin sensitivity, so that can be used. It's linked to increased leptin sensitivity, increased activation of that AMPK pathway, and increased anorexigenic hormones. SGLT2 inhibitors promote glucosuria by reducing renal threshold for glucose reabsorption. We have the Empiric CVOT trial, which showed SGLT2 inhibitors to be having a positive effect in weight loss, but it does increase your risk for urinary tract infections, fungal infections, and dehydration. Now, when medications is not the route, when your BMI is greater than 40 or you have comorbidities and your BMI is greater than 35, you can consider bariatric surgery. Like any surgery, there are risks associated with it. You can have infections, respiratory failure, renal failure, increased mortality, malabsorption in this particular surgery, or nephrolithiasis, which are kidney stones. The options available are laparoscopic banding, Roux-en-Y gastric bypass, laparoscopic sleeve gastrectomy, But gastric bypass has shown to have a significant positive impact in blood pressure and kidney disease. So studies have shown that there has been an average rise of GFR by 26 milliliters per minute per 1.73 meters squared 3 years post-bariatric surgery. And a 6-year post-bariatric surgery study noted that the risk of kidney disease progression was reduced by about 45%. So there's a lot of benefits to bariatric surgery as well. Antihypertensive therapy. So the ACC-AHA recommends pharmacologic therapy if your blood pressure is greater than 130/80, especially in patients with a formal diagnosis of type 2 diabetes, CKD, or cardiovascular disease. ACE inhibitors and ARBs are going to be our first-line medications, particularly in patients with proteinuria or diabetes. These agents act by reducing the intraglomerular pressure and proteinuria, and they have been shown to slow the degree of renal disease progression. They also have cardiovascular benefits to them, therefore they're first line. Now, if ACEs and ARBs are not sufficient, you can add calcium channel blockers or thiazide-like diuretics as well. The CORAL trial demonstrated that optimal therapy, which included ACE inhibitors, calcium channel blockers, diuretics, and statins, when patients were placed on optimal therapy, it was as effective as renal artery stenting in reducing cardiovascular and renal events. Now, the study does emphasize that interventional procedures should be reserved for patients who are considered refractory, who've been given pharmacologic therapy but do not have good control. There's also renal denervation, which is a novel but well-established intervention for patients with uncontrolled hypertension. It attenuates or stops the renal sympathetic nerve activity. It reduces your blood pressure, slows the progression of kidney disease. It improves insulin sensitivity, modulates systemic inflammation. The European Society of Hypertension made it a Class 2 recommendation, saying that it should be reserved for patients with uncontrolled hypertension. The American Heart Association also agrees with that, saying that it should be used as an adjunctive therapy for hypertension, especially in patients with inadequate achievement of blood pressure with lifestyle changes and medication. So anti-lipidemic therapy, the American College of Cardiology and American Heart Association does recommend a high-intensity statin therapy in patients with diabetes or clinical atherosclerotic cardiovascular disease. And it's also recommended in patients with metabolic syndrome and Reno-vascular involvement. Statins lower LDL, it improves vascular inflammation, oxidative stress, plaque instability, and improves endothelial function, thereby preventing progression of kidney disease. The SHARP trial showed that a combination of simvastatin and Zetia significantly reduced major atherosclerotic disease events in patients, regardless of their baseline lipid levels. You can also add Zetia and Repatha, which is a PCSK9 inhibitor, when you need additional control. Anti-glycemic therapy. So the American Diabetes Association recommends a target hemoglobin A1C less than 7%. Early initiation is essential to prevent cardiovascular events and also just provide cardiovascular renal protection. They also recommend a moderate intensity statins for diabetics aged 40 to 75 and a high intensity statin if you have atherosclerotic disease that's already established. The EMPA-REG outcome trial noted that empagliflozin significantly reduced cardiovascular death and delayed progression of CKD in patients with T2DM and CVD, which is cardiovascular disease. The CREDENCE trial showed that canagliflozin reduced the risk of ESRD and renal death in patients with diabetic nephropathy. When treating diabetes, metformin is considered first line unless there are contraindications like advanced kidney disease or GI intolerance. SGLT2 is great to be added early on as it improves renovascular or delays renovascular disease, and it also has cardiovascular benefits. GLP-1 receptor agonists like semaglutide can also be added for glucose control, and also it has that weight loss potential. It's also noted to have cardiovascular benefits, so that's a good medicine to add early on for patients with metabolic syndrome and insulin resistance. But SGLT2 and GLP-1, SGLT2 inhibitors and GLP-1 agonists both reduce renal injury independent of the improvement of hemoglobin A1C. It improves glomerular hypertension, improves arterial inflammation, stops the atherogenic process involved in worsening CKD. Of course, there's insulin, sulfonylureas, but those need to be used with caution in terms of side effects of hypoglycemia or weight gain, which is another thing we want to try to control in metabolic syndrome. So hyperuricemia management. We have xanthine oxidase inhibitors, which reduce uric acid production, like allopurinol. It improves endothelial function. We also have newer medicines like dodenuronad, which shows promising results in enhancing uric acid excretion and mitigating renal injury without an increase in cardiovascular disease. Early intervention in patients with hyperuricemia may potentially delay CKD and may even reduce cardiovascular events. Unfortunately, we just don't have enough trials to say that there is this causality between hyperuricemia and metabolic syndrome. But we've already seen that patients with elevated uric acid have a higher incidence or higher prevalence of metabolic syndrome. So if we do more trials, hopefully we can establish a stronger relationship between uric acid levels and metabolic syndrome and determine optimal treating mechanisms. So in conclusion, I just want to say that, remind you that metabolic syndrome is a multifaceted disorder. It's impacted by insulin resistance, hypertension, increased adiposity, inflammatory pathways, and oxidative stress. There is this growing global burden of metabolic syndrome and its complications. So early screening and the involvement of multidisciplinary teams where you have primary care providers emphasizing lifestyle changes, dietary modifications, recognizing things that can progress metabolic syndrome and develop complications of metabolic syndrome. Upon the diagnosis of CKD, it's essential to bring in nephrologists so we can initiate management to minimize progression of CKD. We need to do further studies to emphasize cost-effective therapies. Unfortunately, with the growing burden across the world for metabolic syndrome and all its small pathways involved, I think prevention is going to be our number one thing, but multidisciplinary teams can help kind of prevent, but when we need specialists on board and treatments, we can get them on board as well. So I have a couple of questions. They're quite simple, but let's see if you guys were paying attention. So what is not included in the diagnostic criteria for metabolic syndrome at this point? Waist circumference, low-density lipoprotein, triglycerides, systolic blood pressure, and fasting glucose.
We are going B as in boy.
Correct. So do you remember the criteria?
Waist circumference. Oh, there we go. Waist
Yeah.
circumference, hypertriglyceridemia,
So-
high systolics, fasting glucose, and low HDL rather than LDL.
Correct. Yeah, so again, remember waist circumference is population specific. And we have, for instance, I said earlier, European population, they have a lower threshold compared to the American population. But triglycerides, HDL, systolic, diastolic blood pressure, and fasting glucose are all criteria that we consider, but LDL is not involved in it. Another question, so which of the following guidelines is not recommended in managing patients with metabolic syndrome? Now, it is a tricky question because a lot of these things can improve metabolic syndrome. So what is the answer here?
Okay, I'm gonna have to phone a friend.
So do we want to reduce hemoglobin A1C to less than 7? Okay, I see nods. Yes. Do we want to start a statin for diabetics? aged 40 to 75?
Yes.
Do we do that in clinic? Yes. What about a blood pressure less than 130/80?
Yes.
That is currently our recommendation. We do want to target a BMI less than 25, right?
Yes.
And then the ACC AHA guidelines right now does recommend 150 minutes of moderate intensity or 70 minutes of high intensity activity. So uric acid, that's the reason, some people might have thought like maybe F is the answer or maybe G is the answer. Uric acid has been associated with metabolic syndrome, but we don't have guidelines right now to say that we want to target a certain level. But because of the strong correlation, I think physicians who are managing such patients should aim for uric acid that's well controlled. All right. Thank you to my mentors and Dr. Ayazu for helping me with some of this stuff. Here are my references. Any questions?
Awesome. Thank you, Dr. Balaji. Do we have any questions or comments? If you're viewing online, please enter it into the Q&A section, and we'll ask for you.
The best treatment for metabolic syndrome is eating pizza at 12 o'clock.
You know what? I didn't get to choose what was for lunch today.
No, I know. I'm glad you laughed. That's good. That's the best thing in the world. One of the things that I really kind of, now that I've gotten a little bit older and the whole thing, I look at pharmaceutical companies don't make money by you getting healthy and getting reborn like brand new again.
Yeah.
So they make money in keeping you sick more than anything else. Stents, I have a high respect. I wouldn't put my patients in more than 2 months, and then I start them on niacin.
I see.
The non-flush-free niacin. There's isoniacin and niacin.
Okay.
Go with niacin more than anything else. And again, you got to read a lot because there's a lot of things that are keeping from you, at this point in time. But seed oils, the American Heart Association recommends seed oils. That is the biggest stupidity in the world. That is sort of like going to a war with a BB gun. You know what I mean? So lard and coconut oil and all those things are, the best thing in the world for anything. And one of the things also that doesn't help you because you increase calcium and also oxalates is almonds, believe it or not. So when you eat a lot of almonds, guess what? You're setting up yourself. So, and again, try not to eat it. The worst meal you can have of the day is nighttime. After 4 o'clock, I wouldn't recommend anybody eating anything.
Thank you. Yeah, I think preventing metabolic syndrome is our #1 goal as internists and family med docs. None of them probably in the audience, but we've been taught, you want to treat the body holistically and focus on preventative medicine because it's better to prevent something than to treat it because there's so many associated complications.
Great, Dr. Balaji. Just a kind of a random question, but when it comes to the difference between the circumference waist between European and American, is that just based on the average in general being higher in the U.S., or is there any other, and I don't know if you saw exactly as to why there was a difference there. That's it. Thank you.
Yeah, no, I did see that even in the Chinese population, the waist circumference is much less, I think 90 centimeters or so for males. I think the build is different for different populations, but the difference between the European and American populations, I did not come across the reasoning for that. But I can look it up and we can discuss further later.
Thanks, Dr. Balaji. That was a very timely and important, relevant talk. I was wondering if you could speak a little bit more about the renal denervation, if you had seen more information about that. It's not a procedure I'm very familiar with, and we have tons of resistant patients with resistant hypertension, so.
I myself have a patient who I've been taking care of since day 1 of residency, and I'm seeing him at 1:15 today in clinic. But he unfortunately has had, I think he's on 5 or 6 different medications. I haven't seen a lot of patients in our clinic, unfortunately, being referred for that. I think when patients are on all the ACE inhibitors, calcium channel blockers, thiazide, all the optimal therapy agents that we have, I think it's a good time to kind of refer them for surgery, see if this would be appropriate. I personally don't have a lot of experience with that to talk more about it, but I can definitely I can look up and see like what the process would be further for that.
All right, thank you very much.